Welcome to the K in Clarity podcast. I'm the host, Mezue. During this episode, we're joined by Sharon A. Williams, the current president of University of Michigan Health Plan and a seasoned industry leader in healthcare administration and operations and in health-related policy. Sharon Williams has been instrumental in advancing integrated care initiatives and in improving quality of care within the healthcare and government program administration space. Williams has been at the forefront of advancing innovative health plan management and digital health strategy within the healthcare space, leveraging over 30 years of experience to drive transformation across health systems, payers, and consulting organizations. Williams' expertise includes launching and operationalizing new health plans, developing payer contracting and managed care strategies, advising on digital health solutions for organizations such as SIBA Health and Grail Healthcare. Her leadership roles have spanned executive positions at WellCare, Ovations, Evercare, United Health Group, and consulting engagements at Booz Allen Hamilton and Navigant, where she oversaw complex projects related to healthcare reform, Medicaid, Medicare, and value-based care. As a strategic advisor and board member, Williams continues to champion innovative approaches to healthcare delivery, quality improvement, and policy advocacy, positioning her as a thought leader in the ongoing evolution of the healthcare industry. In this conversation, we discuss her insights on the complexities of the healthcare system, emphasizing the need for universal coverage, data integration, and simplified processes. Additionally, she touches on her personal experiences that shaped her views on healthcare, the importance of trust between providers and payers, and the role of money in driving change. Sharon advocates for solutions that can lead to high-impact results and describes her vision for the future, which includes a focus on healthcare as a human right and the importance of building a legacy in the industry. If this is your first time tuning in, here's the gist. The healthcare industry is buzzing with innovations, but there's a lot of noise and misconceptions out there. That's where we come in. Because of my experience in the healthcare ecosystem, I've gained a unique vantage point into the industry's inner workings. We're bringing you the conversations that typically happen behind boardrooms and strategy sessions, the real challenges, innovative solutions, and game-changing insights that are reshaping healthcare as we know it. On this podcast, we're bringing you face-to-face with the industry's leading healthcare founders, executives, and innovators. We're talking about the nitty-gritty of building and scaling healthcare companies, the hurdles they've overcome, and the strategies that have led to their success. More importantly, we dive into the personal challenges that come with trying to change a system as complex as U.S. healthcare. So whether you're a healthcare entrepreneur, a medical professional, or just someone passionate about the future of healthcare, this podcast is your backstage pass to the minds shaping the industry. Now let's have Sharon tell us a little bit about themselves. Welcome, Sharon, to the K in Clarity podcast. For the people listening, can you give a brief overview of who you are and what it is you do?
Hey, Mezue. So thank you for having me. I'm really looking forward to talking to you this afternoon. I'm Sharon Williams, and I'm a consultant, been in the healthcare industry for a couple of seconds, and I currently am a president of a health plan, and I advise digital health companies, so I have a consulting practice as well.
Perfect. As you know, we like to do an icebreaker here firstly. And so for my first icebreaker is, if you had to create a universal coverage index, what would it be? And what are the three maybe non-traditional aspects that you would add to it?
Okay, non-traditional. Still, the only kind of traditional measure that I would still want to put out there is cost. Just because I'm seeing that so many people right now can't afford their deductibles and their coinsurance. And we think that consumer-directed healthcare is consumer-directed, but it's not. Consumers really want something better. And I think the non-traditional elements that I would add take the sludge out of healthcare. So the prior authorizations, the peer reviews, all the things that really don't add a lot of value at the end of the day, but they make the process frustrating for providers and consumers alike. I think data integration and data governance is absolutely key going forward. When you look at better developed countries in Europe or in Asia, that they have that data integration so that you don't have to, that the consumer isn't responsible for bringing their mammograms or their data to the meeting, that the doctors have all that information and it's not just system by system or office by office. I don't think that's fair to consumers or doctors for that matter. The other kind of non-traditional element would be medical education, and not just physicians, but of our nurses and allied professionals. I don't think people should have to go into debt to be a healthcare provider. And I think we need to think more about non-traditional providers like doulas and things like that to improve healthcare for women and home visitation. And the last that's really non-traditional is a food quality index. America has notoriously poor quality food, and our food quality is getting worse. When you look at, again, better developed countries, they don't put the dyes, the sugar, and the salts that we put in our food. And as we're trying to help people get healthy, the quality of our food isn't helping us any.
I love the aspects you touched upon there. I think there was one experience that, you had expressed when we spoke previously about how your mother also basically had a focus on these type of things. How could you tell us a little bit about that?
Yeah, I mean, I grew up first of all, I grew up in a household with really good health insurance, and I took that for granted. I mean, we even had braces as kids, and it was all paid for. There was no issue. And I thought everybody grew up like I did, but Mizzou, that's not the case, right? But in addition to that, my mother put vitamins in our food. My brother, spied on her in the kitchen one day and reported out. Mom's putting vitamins in the meatloaf, but it kept all of us healthy. And our neighbors would ask my mom, like, your kids go out and play all the time and they're never sick. We had perfect attendance as kids, and it's because we ate well. We didn't have sodas in the house. If there was a cake, it was somebody's birthday. We didn't have snacks or sweets. In my food, and my dad was actually, this is my bio dad. He was in the food delivery business, and my mother's like, don't bring those cookies and candies into the house. It wasn't allowed. And even dinner, our friends like to have dinner at our house because we had a nice protein, vegetable, starch, but the plate was balanced. And my mom was really very meticulous about that. Now, my bio dad on the weekends, he cooked, and it was kind of a free for all, but it was all in balance.
I wanted to also touch upon, your experience in the industry. And so I know at United Health Group as well as Ovations, you led turnarounds. And so what are some, playbooks that you used really to help stabilize things in the market from what you've done?
Yeah, so it's funny. So I've worked for kind of most of the major payers in the industry, and I started off my career at Blue Cross Blue Shield, but people like to talk about United just because they're the largest. And I can honestly say United was kind of where I got my PhD. You really learn financial metrics. You really learn how the sausage is made. And so coming into the market, I knew there's kind of what I call the triumvirate of healthcare operations. I needed to make sure my operations were sharp, that we're paying claims and we're paying them right, we're paying them accurately, that my contracts were what they needed to be in terms of benchmark to the market, and that we're actually paying doctors and our providers well. And the last element is medical management. And I don't like medical management like the noise, the sluggishness that we talked about earlier. That our medical chief medical officer and our clinical team were really partners to our providers, and that they were partners to community providers. So when I was at United, we had the Evercare product. So I had long-term care, Medicaid. I had the Medicare Advantage. I had the D-SNPs, that's for duals, the Medi-Medis, and institutional SNPs. We had the first Alzheimer's SNP in the country. And so the home environmental assessments, I think, are absolutely key. But the other thing I liked about United, I know a lot of people don't usually say this, but it's the financial acumen. So I knew I had a lot of people looking over my shoulder the entire time. You get a call out of nowhere, and it could be somebody in corporate just asking you around what's happening in your market. And you had to really be able to speak to the contracts that are in force, and be good stewards of the taxpayers' dollars. So that's the part I liked about the experience. And the last piece I would say is working through people. When you're a plan president, you can't do it all by yourself. If I was going into a contract negotiation, I'd bring my team with me so they can see what I'm doing. We'd have transparency. Even they joked, they said, Sharon, you're not going to get on the golf course and make a deal. I'm like, no, this is business. This is professional, and we're going to be metrics focused. So I really try to walk that walk. In my staff meetings with my leadership, I really try to create an environment where it could be safe for people to ask questions, especially if they didn't understand, and that everybody understood how they contributed to the big picture. And that's kind of what I pride myself in. That's how I'm able to turn sites around or
Yeah.
reinvigorate sites and get people to be excited about their work.
What do you think is maybe something people don't really understand about United Health and what they do in their operations there that you think you could speak on really well?
I think they've become the unnecessary boogeyman and maybe the caricature or the meme for everything that's not right within our healthcare system. And I don't know if that's necessarily fair to United. I think there's a lot of good people there. And while there are some unfortunate things that are happening in American healthcare system, it's not unique to United. And so an example I'll give you, because I've worked on both the health plan side and I've worked on the provider side. So I've worked for hospitals and I've worked for provider practices. When you pit like one microsystem against the other, nobody looks good in this manner. And so United has gotten a bad rap, I think, for being very metrics focused, for being very contract oriented. I mean, they are brilliant at the basics. They are brilliant at treasury. That's what they do. But I think what's happening in our healthcare system is because we, as a country, one, have decided that healthcare is not a right but a privilege. And as the working person is getting squeezed more and more in terms of being responsible for more and more out of pocket, and then we're dealing with appeals and prior approvals that this is across the country. This isn't specific to United. And so there's a lot in our healthcare system that's not right. There's a lot in our healthcare system where I think we don't have the leadership that some other countries have. And there's a lot where people just don't know what to do. We're a country that prides itself on individuals having grit, but it's hard to have grit against systems that are just so big and cumbersome and unnecessarily complicated, quite frankly.
I think I want to speak on the aspect of complexity. Obviously, I know you help simplify processes. And so maybe what are some go-to-market strategies that you use to really help simplify the complexities between, payers and providers, really, while ensuring you still have the same type of quality standards?
Okay, so that's a great question. And I'm having a flashback to like my first job out of grad school when I was young. Not say naive, but very idealistic. And I happened to work for the largest payer in the market. So when you work for the largest payer in the market, where I'm talking 70 to 80% market share, you've got a lot of gravitas. There's a lot you can do there. So a couple of things I did. The health plan was taking over managing its products and primarily the commercial product from a TPA. So I had a chance to really build it from scratch, build it from ground up. So on the commercial products, I looked at national best practices, even things from like women's health care, reproductive services, and just making sure it was spelled out. I try to remove a lot of the co-insurance from contracts because people don't understand when they have co-insurance what their actual responsibility is, and created more flat co-pays. Because now I know if I go to the doctor and I owe $5 or $10, I know what that is and I can budget for it. We removed all the co-pays for preventive services because we didn't want any barriers there. And we created like basic English contracts that anybody can understand. And I point that out because, in the industry, the joke is Medicare Advantage has like a 300-page member handbook. Who is going to read all that and understand that? That's just crazy, right? So you could tell the lawyers came up with that stuff. And then we simplified the language in our EOBs, explanation of benefits. We simplified the language in the EOPs, the explanation of payment. And so that was one thing we did. The other thing we did was we really reduced a lot of the prior authorizations. And then the few that we had, we worked with the smaller health plans in our market. And obviously, we had the lawyers at the table, so that it wasn't that we were kind of violating any market any laws around conspiracy or health plans coming together. We had the lawyers at the table, but we were able to agree on a certain set of disease states and dollar amounts where we would have prior authorizations. Because if you look at the industry from the provider standpoint, if every single payer has a different prior auth, has a different vendor. That makes things more complicated for the provider. And we really tried to simplify that. And we really cared a great deal around the provider experience. And then it also improved the patient experience. And then the other thing that I'm kind of proud of is that our employer contracts won awards. We won awards for comprehensive women's health, and that's something that I'm passionate about. We had mental health parity before mental health parity was cool. Everything was really neat and understandable. And I wish I could have kind of replicated that experience in other places.
I think with what you said there, there's a lot of change, right, that's happening. And I think things are important on that side. But how do you ensure that you have the same quality of trust with providers while you're doing this operational overhaul, right? But ensuring that you're also making the lives of patients way easier without risking too much.
Yeah, and I think that's more art than science. That's the easy answer. And I just want to say that I think the healthcare industry has lost a lot of trust on both sides, on both the consumer or the patient and the provider. And I think we need to care about that. And that's not easy. I remember when I was interviewing for a job with a payer, the CEO had asked me, "What do I think about providers?" And I thought that's such an odd question. I mean, because we don't exist without providers. I think there has to be some respect there. And in my experience, when I was rolling out things like ACOs or bundled payments that were brand new, to take the time to really go through all the data to create a safe place where people can ask questions. And quite frankly, that takes time. And so while you may want to do an upside risk agreement day one, there's no doctor that's going to take that. There's no provider that's going to take that. So you say, okay, let's do upside only for the first couple of years. Let's get used to the data. Let's get used to making sure that this makes sense, that your team knows how to read the reports, that our reports are accurate. I don't assume that everything we do is perfect and that we're coming down from Mount Olympus with all the answers, that you've really got to have mutual respect at the table. And so I've always had respect for our providers. Like when a provider calls me and says, Sharon, I didn't get my payment, or I didn't get what we need, even a vendor, I care very deeply about that. And I try to escalate those things, within whatever infrastructure I'm working with, whatever health plan, whether it's the Blues, Centene, or whatever health plan I'm with, because ultimately, what patients care most about is their provider and their relationship with their clinical team, and we should facilitate that and not be barriers to it.
I know when we had our discussion previously as well, you said something to me that hit me, which was,
Okay.
healthcare is a product like no other. And I think I want you to dive into that and, why you believe that. And I think also as well, what are some things that you think are in other industries that shouldn't apply to healthcare and why?
All right, that's a simple question. Okay, but as soon as you asked it, I was thinking about my traditional education in microeconomics, University of Chicago, and some of the other schools that I attended, and we'd get into these conversations about, is healthcare right or privilege, and then they would apply the market, right, basic microeconomics to it, supply, demand, cost, value, like there's nothing else to consider. So I self-identify as a humanist, meaning I really care about people, and I think everyone should have access to health care. And I don't think healthcare should be politicized. And I think if we had universal health care, we would have fewer disparities in outcomes. And there's enough studies to support that statement. This isn't just Sharon's opinion of the world. And so it starts with that there is an innate value in humanity, and that healthcare access becomes healthcare privilege. Then I'm also reminded about a joke that Chris Rock said about, his wealth and his journey, right? This isn't the Robitussin joke. We could talk about that later, but this is where, when he was starting and he didn't have a lot of money, his dad died of a preventable disease. And then he had a lot of money and his mom got ill, and he had the money and the resources to get her that care that she needs. I don't think our lives should depend on whether or not you have money. And I want to take it in a slightly different direction, that when you think about the US healthcare system, when you get sick and you present yourself to either the emergency room or to your provider, what's the first question they ask you, Mizzou? Do you think about it? When you go to your doctor, what's the first question they ask you?
I believe sometimes it has to do with the insurance card, but I don't know.
Yeah, it is. It
Okay.
is. Show me your ID. Show me your insurance card. Tell me how you're going to pay for this, and you sign. That doesn't happen in other countries. Just think about this: when you're at your most vulnerable, you're sick, and they're busy asking you to fill out some paperwork. This is why data integration or systems are important. And you have to remember your history and all this other stuff, that if we had it automated and integrated, you wouldn't have to be asked those questions or answer those same questions over and over again. And the second thing is, how do you pay? Because how you pay is going to determine the kind of care that you get. And there's enough studies that show that. And I think if we truly believe, that human beings have innate value, if we truly believe that all people deserve health care, then those shouldn't be the first questions that we ask. And I know, sure, as I say these words, I don't want to sound like I'm naive. I understand that we're in the United States of America, and not everybody believes what I believe. But I think that's where leadership makes a difference. And I think Americans are so nickel and dimed, they don't understand that government is the solution. Government is where people and businesses go when there isn't a solution in the private sector. And I think the private sector has proven it cannot control costs. The United States is subsidizing pharmacy and medical supply costs for the entire world right now. Let's take GLP-1s, right? Everybody wants them. And by the way, not everybody's going to get them because they're expensive. And the average price of a GLP-1 is twice as expensive as Canada, and sometimes 2 to 3 more expensive than what they're paying in Europe. Why is that? Because we don't have price controls in this country. And the average health plan, the average health system, and sure as heck not the average consumer can control that. There has to be some protection. So that's why we're not a product like any other. I don't want to leave it to the market.
A big take.
It's a big take. Yeah, it is. And I remain hopeful that we will get to the point where we will have some type of universal coverage. I think ACA has proven how important healthcare is, and how healthcare insurance is healthcare access, and how difficult it was to get rid of the ACA because people are like, I really need health insurance. It's not even like car insurance. It really is life or death.
I was speaking to another leader, and one thing that they had mentioned is that really to bring about the incentives, to bring about change, they've been on the payer side, they've been on the provider side, they've been on all the aspects that you can think of. And basically, one thing that they said is the only way that things are going to change is when it comes down to reimbursement and how money is moved around to really help bring about the change and focus on the patient, right? Which is what we want the outcome. You can't have the patient in care, like you mentioned, but you also can't have the provider, right? There's all these aspects and stakeholders. And so do you think that leader is onto something there? What are your, thoughts on that side?
Yeah, I think that leader is spot on. And you want to break it down even further when you think about the fact that there is variance in products and variance in reimbursement. Where there is variance in reimbursement, you're going to have variance in outcomes. So we know that the PPO products, preferred provider organizations, that's probably one of the highest rates of reimbursement. After that, it's commercial HMO. After the commercial HMO, you get into Medicare rates or other government rates like the VA and things like that. And then at the bottom of that is Medicaid, right? So if you're a doctor's office and you have limited capacity, and we already know that there are shortages, the variance in fee schedule is pretty much is the priority for getting into that doctor's office and getting that slot. And if you want to and you really want to change the variance in outcomes or reduce disparities, then we would have one fee schedule. Now, granted, that one fee schedule has to meet the doctor's costs or the provider's costs, and it has to be equitable and has to be fair, and there has to be regional variance. But all these different fee schedules, it's administrative costs. That's part of the sludge. It creates a variance in outcomes, and they're difficult to administer. So yes, if you want really want to change the system, you have to change how we're paying for it. And part of how we're paying for it isn't just the care itself, but also how the clinicians are educated and who's paying for that and what are we paying for and what specialties are open. So I know you haven't asked me the AI question yet, but it's coming to mind, right? So with AI, we know that the AI radiology results are more accurate than human, right? And so if that's the case, then we should be one, reimbursing for radiology AI reports. And then two, we should be closing down the specialty for radiology and opening up more spaces for primary care. And so there is a lag between what we know, the trend, and how we are responding to it. And we clearly need to educate more primary care and more physicians and more kind of basic specialties.
I know as well, you've partnered with, major health systems. What's maybe a counterintuitive lesson that you've learned in, aligning goals and incentives, with the hospitals and, the goals and incentives of a payer? What's something that you've learned there?
Okay. I'm trying to what can I share that's politically correct. I think one of the things that surprised me initially was how little the both sides understand each other. So the health plan world can be somewhat isolated. The health plan executives tend to circle among all the different health plans. The hospital world or the health system world tends to be somewhat isolated. They tend to pick some of their own people. It's not until fairly recently that they really start hiring people from each other's industries so that they can get a better understanding. But even as a consultant, and I've worked for some of the top consulting firms and having my own consulting practice, I continue to be surprised by how little people understand health insurance, even the people in the industry. And I remember one of the locations where I was working, there was a COB letter. It's a coordination of benefits, right? It means you've got a primary insurance, you may have a secondary, and it's pretty standard in insurance. They send them out just to make sure if there's another source of payment or that they can get that. One of the hospital execs showed me the letter and said, "What is this?" I said, "It's a COB letter." I thought nothing of it. But it was the way he asked me and the way they talked about the tone of the letter, it really made me, I thought about it all weekend. Actually, I thought about the tone of our basic letters in health insurance, and they're a little edgy. So health insurance is a little edgy, and I'm grateful for this experience that hospital exec brought to me this letter. It was very super smart person, on point, but his question was around the tone. And is this what we do? And I was like, yeah, this is what we do. And that was my initial brush off that, you know, um, these doctors are frail. But no, we're a little edgy. So I'm grateful for hospital executives kind of asking me basic questions because it's got me thinking about kind of everything that I've done as a health plan executive, the advice that I give other health plan executives as a consultant, and it just helps me kind of rebalance my thinking and being more consumer oriented. I pride myself on being very provider friendly and consumer oriented, but that question of something so basic had me just rethinking kind of everything that we do in this industry, and I'm grateful for that. So, you know, the health plan executive in me needs to have more conversations with health systems leaders so that I can really keep as open minded as I like to think I am. And then when I get into it from within the health executives and talking to the health systems executives, I try to impart, hey, this is how the payer is seeing this. And I wish somehow that there was a position where I can kind of facilitate health plans and health systems in a market to create the change that I would love to see.
I think that's something that I've seen as well. It's really the basic stuff
It is the
that
basic stuff,
will
yes.
change everything, especially from the patient side of, hey, like if I heard it in this way, right? Or the language that's used, or even cross changing, like you just mentioned on the payer side or the provider side, those tiny things can really make a big impact. And that's something I'm seeing, and that's something that I've been told, you know?
I think you're spot on. You're absolutely spot on, and it is something so basic, right? And it's got to be grounded in mutual respect. And I just had a conversation earlier today with a vendor, and I was just listening to the vendor, and it finally dawned on me. This vendor feels disrespected. It took me about a half hour into the conversation, but I'm a root cause person, right? So I'm trying to get to root cause. And he keeps restating his issue over and over and over again. And I realize he feels hurt. And I had to take a moment and I said, okay, Sharon, get your ego off the table and just say, I'm sorry you feel hurt by this. And now how could we move forward? And sometimes it's as simple as that. And in healthcare, that often doesn't happen. And I'm reminded by, something that happened to my brother. I have a brother who is, learning disabled, and he went in for knee surgery in New York, and he coded on the table. And he was really scared. He really needed this knee surgery. And he also likes to play it tough because he's a guy, right? And my other brother who lives in New York was called in because he's physically there. I'm in Atlanta. And he's like, Sharon, I can't deal with this. I can't. You need to talk to the doctor. And he just checked out. So my brother, who was supposed to be the advocate, just checked out. He couldn't deal with the doctors. He couldn't deal with the anesthesiologist. And they circled the wagons. The hospitals circled the wagons. And my poor brother is there, in his hospital bed, scared. And my other brother, who's supposed to be advocating for him, is scared too. So I'm on the phone trying to talk to these people, and they're like, "Who are you?" I'm like, "I'm the sister." And they're like, "Are you a doctor?" Because I start asking them questions in their language. And I'm like, "No, I'm not a doctor. I'm just advocating for my brother right now. He's okay, but he's scared. He will never get the knee surgery that he needs. He will not do it." And the way the hospital talked to him and the way they treated him and even the way they talked to my brother was not adequate. So to your point, Mizzou, just about speaking English. And they were trying to talk over his head. He's tired, he has a job, and he's emotional because his brother's hurt. They just checked out. And that happens to so many people all over the country. And as I called my friend who lives in New York, she's a nurse, and then her best friend works for a law office. I said, "Do we have a case here? What's going on?" I needed someone to be objective because I was getting emotional about my brother too. And the nurse is like, "Sharon, this is more common than you can possibly imagine. There's no case here. This is just typical." And then my brother, when he got out of the hospital, he's calling me saying, "Fix it." I said, "I can't fix this for you. And I'm sorry you were treated this way." He's like, "This doesn't happen on TV." No, but this isn't TV. This is real life. And he's somebody who will never trust the healthcare system in that way again.
Mm, that's very sad.
Yeah, but it's stuff like that that keeps it real for me. That as I'm negotiating contracts and I'm talking to providers or health plans or vendors, I try to keep some humility. It may not seem like I have humility, but I do.
No, I definitely feel that in our multiple conversations. So there's no way on
Okay.
that side.
Yeah, yeah. You haven't sat across me, negotiating a contract. So sometimes they're not feeling it. But I do, and because I'm trying to make it fair for everybody, I really am, but I can truly see all sides.
I think going back to that, seeing all sides, you've been in industry, as you would put it, you've seen the sausage making, and so with your experience and your background, how do you go about really clarifying and navigating and really explaining to others with data storytelling about the system's opacity and what's going on to really bring about that actionable change?
Yeah, so what I tell my board is I know enough to be dangerous about everything. When I say everything, it's I've touched everything from product design, benefit design, how the claims are paid, how they're denied, the appeals and grievance process. I've managed call centers. I've listened to provider and customer complaints. I've sat in on credentialing meetings. I've done work from the policy perspective. And so, when a team member comes to me, regardless of where we are with, "Oh my God, this is happening." And typically there's a visceral reaction, like, "We're getting all these appeals, we're getting all these appeals." I say, "Okay, so what is the number of appeals? What is the dollar amount?" I get almost Spock like in my analysis that I want them to get very quantitative about how big is that. and who are the providers and what's the story we're going to tell, right? Because at first it sounds big, but if you say, okay, 80% of the issue are two providers, then it's gotten a lot more doable. It's gotten a lot more understandable. So when I'm dealing with team members who are particularly in distress or concerned about something, the very first thing I do is just listen. I honor exactly what they're feeling. And then we get into, so how do we quantify this? And the quantifiable is the story. So maybe that's my economics training, where the algorithm is the story. And I love that. I know not everybody does. But here's the thing I learned is that when you take them through the process, they've got to do it, right? They've got to create the reports and then they look at it and they go, oh, this is what we're doing. So when you go into the meeting, you're not going into the meeting. And by the way, this is true for both the provider and the health system side. When you go into the meeting, you're going into the meetings with facts that are objective rather, and you start with the facts. And then you try to get agreement on the facts. And then from there, you can have a more successful negotiation. Now, it doesn't always work. Because again, if the undercurrent is all feelings, I feel hurt or I feel disrespected, and then you got to deal with that too. And you've got to deal with how did we get here? And sometimes that's a little bit more qualitative. Sometimes it's pent up history between microsystem to microsystem, but you've got to give space for that, give space for the emotional, and then you migrate to the metrics. And I tend to lead by the metrics. And the other thing I do, and I think I do it well, is I try to create an environment, one where you can disagree with me because I'm not God. I'm good, but not God. I've got two O's, not one. So let's have a conversation, right? And then let's collectively come up with a plan to go forward. And so I think my team members feel empowered. Almost, oh, I shouldn't have used that word, but it's where they understand that they're the solution and that they could make a difference based on their work. Or a conversation I had earlier today, as I said, you know what? Let's go with your basic report. Let's do that. Let's not create more work. And she was like, well, thank you, Sharon. Thank you for not trying to create more work for me. I said, I'm trying to make life easier. Let's not lead with the most complicated. And then let's give our audience a chance to respond. If they want more, then we'll manage it going forward. So I really try to take a look at the hard work people are doing. I acknowledge that, by the way, because I do work my teams hard. And I say thank you. And if they want to do something different, I try to stay open to that. Or I've had team members say to me, Sharon, you need to do blah, blah, blah. And they'll tell me what I need to be doing. And I'm grateful for that because to me, that's teamwork.
That's beautiful. I think pairing with that, the story of your brother, how you use data. What are some things, because I know you had mentioned this previously as well, so Americans need healthcare done well. And so what are some, low tech but high impact solutions you think could really bring this, result about?
Low tech, right? Okay. I'm going to say being brilliant at the basics. It's not sexy. It seems to fly in the face of all the digital health solutions that are out there right now. So what does it mean to be brilliant at the basics? It means you're answering the phones. You're listening with empathy. Empathy doesn't cost any money. And you're really trying to create responses to the patient or the end user. So I think the whole kind of call center mentality is really to me about concierge and picking up the phone like it's your mom or it's your brother on the phone. And one of the health systems I used to work with called it the mother standard of care. And my mom calls it the mother standard of care. So like when she asks me questions about being Medicare Advantage and what's going on, with my pharmacy benefit, when I start to give her the insurance executive answer, she's like, "No, I don't want to talk to the insurance executive. Get that woman out of here. I want to talk to my daughter." And then I was like, okay, let me break it down. The other thing is just paying claims, and that's such a basic thing. But what I want to talk to you about, Mizzou, on paying claims is, so you have health systems that are upcoding. You've got health plans that have edits on their systems that will uncode and unbundle. We keep playing these games back and forth, back and forth. I want to go back to your conversation on the fee schedule. Again, I think that health leader had it right. If we could simplify fee schedules, low tech, I mean, really, like get rid of Okay, nobody, this is my opinion, nobody else's. I'd like to get rid of Chargemaster. I would like to have one fee schedule across all products, Medicaid, Medicare, commercial. Use one base. Now the dollar amounts may be slightly different in the short term, but in the long term, in my utopia, it's one fee schedule in a region, right? But in the short term, if we really want transparency and you want people to understand how much does this cost, right? I think one fee schedule would really help. That could be amazing if we could do that. And the last low tech thing is really getting rid of a lot of the prior authorizations, the peer reviews, the sludge in our healthcare system. And then the last thing is get rid of the paper. The EOBs, the explanation of benefits, the EOPs, explanation of payment. I know CMS thinks they're doing something good here, but the average person doesn't understand all this paper. And I'll use the example of a friend of mine whose nephew went to school in Germany. He was messing around, got hurt. I think he broke his wrist. The only thing he got was a €5 copay for the pharmacy. No paperwork, no nothing. Okay, and you think about just going to the doctor's office, you get the paper that comes the explanation of benefits. Even going to CVS, the joke is how long the receipt is when you get it. We really love paper in this country, and if we could simplify, if we could simplify things, I think people would it would really enhance the consumer experience.
Tying back to what you mentioned about CMS, I know you've negotiated shared savings contracts, and so how can you really focus and reward prevention over treatment in Medicare and Medicaid?
I know you're saying Medicaid and Medicare. I will argue it's the same thing on the commercial side too. So while Medicaid is a federal program, it's administered on a state by state basis. So all the state by state variants. If you've seen one Medicaid plan, you've seen one Medicaid plan. So that's another reason why I'd like to see one fee schedule across the continuum, reimbursed for prevention and for physician time, because 15 minutes in a doctor's office isn't a lot of time to get to root cause or have quality conversations. I don't care what anybody says. And so even while there's more payers buying up primary care, they're not changing the primary care model. And so I'm going to split the question. One is we need to evolve the primary care model that we're reimbursing. And I think I'm a fan of global payments. I'm a fan of bundled payments so that we pay the clinicians time to spend with the patient and to get to root cause. I'm also a fan of labs and comprehensive labs, and that the lab would be included as part of that payment. And so it's not enough to just say, I'm going to buy primary care, because I think that's what a lot of the payers are thinking, and I'm going to control the access to specialists. Unless we change the primary care model that you're reimbursing for, you're not going to get a change in outcomes. And I think we need to pay providers for their time, and I think we really need to take their exhaustion and they're being overwhelmed by the complexity of the payment models into consideration. And if we made things simpler for the providers, and they could spend more time on what they're trained to do, and that is deliver care and not have to be coding experts or some of those other things that we're demanding of their time. The last kind of piece of that is as we're reimbursing them for a quality experience, the other thing I just want to tie it to the conversation on universal care. The reason why universal care becomes important is that, and by the way, I'm not saying single payer. I'm absolutely not saying single payer, because we don't have an infrastructure for single payer. This is definitely a public-private partnership. But if we offer universal coverage, then you've got a broader risk pool. By creating a broader risk pool, you don't have to worry about, am I only going to have this patient for 6 months or a year as they change jobs, as they change lifestyle? You've created a platform that creates a better incentive for keeping people healthier, because now you've got them in the risk pool for life, cradle to grave and not just based on a job or based on where they are in terms of Medicaid coverage. Some states allow for 6 months, some states allow for a year, some states are month to month. So, as you think about the primary care model, juxtaposed against what happened with redetermination with Medicaid, I think that was just cruel how we treated all those people and just kicked them off the rolls. I mean, these are people who all of a sudden won the lottery and now they're wealthy. They just didn't fill out paperwork. So they're caught in this administrative hustle or administrative gotcha, and that's going to impact their care. That's going to impact the quality of their life. So that's the other reason I'm a fan of universal coverage so that we can get broader risk pools and we can really be about population health. Because all the things we're doing now, all the disease management programs, all the digital mental health providers, it's all sexy stuff. But that's not going to get us to where we need to go in terms of extending our lives, extending the quality of our lives, anti aging, some of the things that we could be doing to really help keep people healthy and not wait till they get a chronic illness.
How do you think this ties together maybe with accelerating value-based care within a couple years?
Value based care is not moving as fast as I think it should. And because we are subject to administration changes and whatever it is that they would like to do or focus on. So there's a lot of talk around value-based purchasing, value-based contracts, and a lot of it is we want to bundle more things so we can pay you less. And I don't think that's the direction we need to go in. And if that's what somebody means by value-based contracting, that's not it, but that's what's primarily out there. And so if we really want to be about value-based, we need larger risk pools, not smaller risk pools. And we need to get a handle on real population health. And we're not doing that. And so that's the marketing on value-based contracting is the myth that a microsystem can make a difference. And when you have microsystem against a microsystem, whether it's payer or provider, and both can be very well intentioned, we are not going to get the population gains in the quality of life that our counterparts are seeing in Asia and Europe because we don't have real population health at the table.
I know your experience, as a startup advisor, and that's something I want to touch upon. We discussed a lot of challenges. How do you think, maybe startups, without maybe always doing the things that are so sexy, as you mentioned, can really play a part in bringing about change and innovation? That's something that we talk a lot on this podcast. What part can they play in this whole process?
Yeah, so I think, again, my answer is twofold. I think the digital health space needs some kind of quality control because everything isn't everything, right? So we've got about 10,000 behavioral health platforms, and they're all kind of line extensions of each other. That to me is not going to move the needle. And do I think mental health, behavioral health is important? Absolutely. But again, you need health insurance to get the access to mental health. And it can't be just about providing it to commercial insurance or to the people who can afford it, because your conversation earlier, Medicare and Medicaid people need this technology too. And then there's a lot of barriers to getting into health plans to do that. But again, the radiology AI, the generative AI, some of the stuff that's happening in terms of tools for clinicians to deliver their notes and integrate with RevCycle, and so they don't have to be so focused on keying in or data entry. A lot of the administrative support, I think, is fabulous. And again, there's a lot of noise in that area, but anything that can create more space for clinicians to spend more clinical time. But what I don't want to happen is we freed up some clinical time, so then we're going to change the metrics for clinical productivity, and then we run our clinicians into the ground. I don't want to see that happen either. The other is in some of the disease states where the generative AI is really a phenomenal predictive model in terms of preventing surgeries and integrating with genetics and custom solutions and in custom or precision medicine. That's incredibly exciting. And I'm actually talking to someone right now in the oncology space that wants to use her predictive model to reduce unnecessary surgeries in the oncology space. That's phenomenal. That's the kind of stuff that I'd like to see expanded. And the last area that I am excited about is root cause medicine. So, and I worked in the past with a provider in that space. And I think the root cause medicine or functional medicine, whole health medicine, bringing that to scale, and especially getting it to the Medicaid and Medicare populations who typically do not get access to root cause medicine. And what does that mean? That does mean looking at the person at whole health, running genetics, running a series of labs that's much more comprehensive than what most primary care is doing today. It's kind of like advanced primary care model, and really sitting down with the patients and helping them understand their labs and not just what is minimal, but getting this conversation about what is optimal. And if they have a chronic illness, what's really exciting about the GLP conversation isn't the cost of the GLPs, but it's that we can actually reverse chronic illness. We've never talked about that in the past, and that we're talking about obesity as a chronic illness that can be reversed. And so that's where the technology I think is super exciting.
I think in your work as, startup advisor and what you do day to day, I know you say that, you want your teams to think creatively with constraints. And so how do you think that's something that you really help enforce with them in all these risk adverse environments that we're in, particularly in healthcare, to really bring about, change?
Yeah, that is really difficult because the theme I think for the last month for me with one of my teams is MVP. What is the minimal viable product? And these are people who give 150% every day. And I'm saying, no, right now I need you to think about 95%. I need you to think about what meets our compliance, risk assessment, and having a conversation around risk assessment, around reputation assessment. And again, helping the team be part of this conversation. So sometimes I do it in small teams, one on one, two on one, if it's a specific issue. And then one of my compliance officers actually raised the issue to 30 people on the phone. Now everybody got quiet when he asked the question around reputation assessment, but I could see the smoke coming out of the ears, like they're thinking. And so again, trying to create space for people to think about what are the elements of risk assessment, what is manageable based on our limited resources, and also trying to think critically around limited resources. I feel like for most of my career, I've been asked to operate with limited resources. And I'm like, who are these people who get all this money and all these resources? But that hasn't been me. But I also do it knowing that everybody on the team is looking at me. Right. And so it's leadership from the top down. And I do think leadership matters. So my team knows I would never ask them to do something I'm not willing to do. Like nothing is beneath me, below me. Everybody on this team is important. Whether you're the medical director or you're an administrative assistant, everybody is important in every role. We're all in this together. And I think that's where leadership makes the difference. If they see me being conservative with my expenditures, if they see me willing to help move boxes or really struggle with trying to make some decisions about what do we need to do going forward, they see that and they appreciate it. And I think the other thing I do when there's limited resources and a lot of work is really share that this is tough. And so this isn't just a Pollyanna leadership style. This is, hey guys, I hear you, I see you, I'm struggling with this too, and we're going to get through this together.
I love that. In your role, right, obviously at UMISH, in the health plan as a president, right,
Mhm.
how are you really pushing along and what will you think, you're leaving your legacy there as a metric of success and really pushing towards, your perspective as, coverage is a human right. What will really define your success metric at this organization?
That's a tough question. It's I'm glad you're laughing because I think about that a lot. And by the way, these are my opinions once again, not the opinions of the University of Michigan. But, so number one, it is a powerful brand. It is bigger than me. It is bigger than us. When I speak at a national conference and I say I'm from the University of Michigan, people come up to me afterwards and go blue. They're just passionate about it. And I am kind of very humbled in service to that brand and in service to what it means to people that the University of Michigan is an institute that really cares about its people. So when I interviewed for this role with board members, they talked about how important their relationship is to their community, their role in how they treat their employees in a way that I've never heard in any other place I have ever worked ever. Period. And so as I think about my contribution, how do I do some of the tough things we have to do with integrity in honoring every individual, their history, their contribution? Because I'll tell you, I've worked with a lot of amazing people throughout my career. These are some of the finest individuals I've ever worked with. Really, truly decent human beings. And so I think my legacy is how to honor them.
It's beautiful.
I hope so. And I hope my team members feel that because
Yeah.
I feel that about them.
Yeah. Yeah. I think that's something that you're doing well. So I would love to see it from here. Now going into, our last question, I'm going to combine these two a little together, which
Okay.
is what is some archaic processes that you see in healthcare
Oh my
and what would you really change in there? I know there's a lot.
God.
And then also, what would that system really look like, to you? And obviously, I know this is your own opinions, but I want us
I
to
know.
get creative
Oh
here.
my God. Oh my God. That's a 10-part miniseries right there.
Yeah,
Actually, you could do a podcast just on archaic processes and procedures.
yeah.
Oh my gosh. I think, again, as I think about that question, the very first thing that came to mind was we need to stop pitting microsystem against microsystem. So as we think about solutions, how to think about them at a market level. And so what's archaic is asking, these contract negotiations, and they've gotten to be really time consuming, very contentious, and it doesn't need to be that way. And there's got to be a better way. So I think trying maybe to create market level rates of reimbursement, market level care coordination, and really make things easy for the consumer and the provider. And I think that can be done with the right leadership. And I'm trying to think about in terms of what I do next, where's a market where I can do that? How do you streamline these prior authorizations and all of these gyrations that we make providers go through to get their patients care? How do we do that? And how do we elevate the HIEs? They're kind of archaic, but we need real-time data, and everybody says that. But if I go one place to get my doctor's appointment, and just because I go to another place within the same hospital and they don't have interoperability, that's archaic to me. When you have better developed countries that have everything on the same platform. And you can argue most of the market's going to Epic, but there's so many different iterations of Epic. We're going to need a way to have it a higher level of interoperability than we have today. I think that's kind of embarrassing. Getting rid of the paper, I think the paper is archaic. And the last thing I would love for us to do is to get simpler benefit design. I think coinsurance should be abolished as archaic. I think I know the hospitals aren't going to be happy with me saying this, but charge master is archaic. And we really need to really start simplifying and simplifying and really think about a mother or brother standard of care for everyone.
I think we've done well so far. I think now it's time for the lightning round. Are you ready?
Okay, all right, okay. A lightning round, all right. Yes, sir.
So my first question for you, is what do you think is the most overlooked tool in member engagement, particularly, in Medicaid?
Okay, okay, lightning. So leveraging their EBT system, because that's where they get paid. I think we need to meet them where they are. So EBT, SNAP, all of that needs to be integrated. And then if we want to communicate with them, being able to communicate with them on their platform, go to where their money is.
My second question for you is in one sentence, what do you think is a 2025 policy change that can happen today that would really go about bringing healthcare accessibility, to people?
Okay, I'm nervous about that question just because of where we are with our current administration. I gotta qualify it. So I don't know where they're going, but the one direction I feel like they're going to go in is improve food quality. And the other direction I think they're going to go in is maybe some drug pricing controls. If that happens, that'd be a good thing.
Okay. And my last question for you is, what emerging trend do you think will be a force reckoning within healthcare by 2035?
The emerging trend, demographics, aging population, browning populations. And if we're really going to be about precision healthcare, we're really going to have to take culture, economics, and age into better consideration than we are today.
What do you think that'll look like if you had to go deeper?
Well, I thought this was lightning round. How dare you?
Sometimes if it intrigues me, I go a little bit deeper. I want to know.
Okay, no, no, you're allowed. You're allowed. This is your podcast. What does it look like? I think it looks like companies, like out in California that are thinking about like Asian specific health delivery, like East meets West medicine, and they're building that into their benefit designs. They're building it into the networks that they're developing to make sure it has people who represent their population. I think it means that we're gonna put more people of color through medical school and through clinical schools and not just nursing, because the studies show that when you have people of color and people of diverse backgrounds in the clinical arena, you get better outcomes. Indisputable. And I think that's going to happen as part of the demographics. And then with the aging population, some of the, going back to your question around prevention, especially among more affluent seniors, I think it's going to start with them first. They're going to demand more prevention, anti-aging care to have better quality of life. Some of that you're going to see through functional medicine, root cause medicine. Some of it you're going to see through East meets West medicines. And some of it I think you're going to be on a demand for better food supply.
Another question came to mind, so I'm going to ask you this:
Okay.
what are your thoughts on concierge care?
It's great for those who can afford it. And among a lot of my friends, they can afford it and that's what they're doing. But again, you're creating two, three, four tier system healthcare. And if you care about health equity and you care about disparities in healthcare, the other reason more doctors are going into concierge medicine is they don't want to deal with all the insurance companies, and they don't want to deal with all the payment. You could pay me cash, and I could do what I want, and I can work with somebody who is incentivized to take care of themselves and is going to listen to me. Why wouldn't you do that?
Okay,
So I care about population health. I care about health equity. So if you can afford it, America is fabulous for those who can afford it,
that's true.
right?
Correct.
Yeah. So, and I'm not knocking it,
Okay.
but I think we've got to worry about, again, this is the humanist in me. I care about those who can't afford it. And I don't like walking over people on the way to work. I think we have enough wealth where if we really had enough strategy and we really had enough leadership, we could do this. We can afford this. We're paying more per capita than any other country in the world, and we've got less to show for it. And everybody knows it.
Well, Sharon, I think we've touched on a lot of beautiful topics today. What are some final thoughts that you have for the audience?
I just want to say I like your approach to the interview. So thank you for this time. And I think for your audience, I think they know probably by now they're talking to an idealist. And I really want America to live up to her promise. And that's what I'm working towards. And if anybody's listening and they see me and they want to work towards this as well, please reach out.
That's my next question for you. Where can people connect with you and reach out if they want to engage?
Well, I'm on LinkedIn. I think that's the best place to find me, Sharon A. Williams. And I do respond to people who reach out with cold calls, with digital health ideas, who want to come together and, create a better healthcare system. We have a lot of smart people. I think we need some leadership. And I think a little idealism hasn't hurt anyone.
Yeah, that's beautiful. Well, Sharon, thank you for your time today. And this
Thank
is
you.
the K in Clarity podcast.
Appreciate you.
Bye.